Good morning, everyone. I'm Alan Simpao. I come from the Children's Hospital of Philadelphia, where I'm an anesthesiologist, pediatric anesthesiologist, who also is part of a smaller team that takes care of low-risk mothers with high-risk fetuses. And it's an honor to be here this morning and speak with you. We'll be talking about anecdotes and basics and cases of maternal fetal anesthesia. And I have no disclosures to share, no conflicts of interest. And as the title suggests, I'll be talking about fetal characteristics that necessitate interventions. Those interventions include minimally invasive procedures as well as mid and late gestational open fetal surgery. And then also go over how we manage these cases as anesthesiologists. This is a heavily photoshopped photo of where I spend most of my waking hours. This is the Children's Hospital of Philadelphia, CHOP. And the bright pink arrow points to where the CHOP Center for Fetal Diagnosis and Treatment is. So it's a wing within the Children's Hospital that consists of labor and delivery floor, 2 operating rooms, and a neonatal resuscitation room situated between the two. So it's almost like a hospital within the hospital for, again, for low-risk mothers with fetuses with unfortunate conditions. So taking a step back, in the 1950s, there were about 4 million births per year. And as you can see, there's a subset of those fetuses that had conditions causing death or major disability. And at the time, in the 50s, there wasn't much that could be done. You fast forward about 50, 60 years later, and over time, techniques, research, advancements in technology allowed us to create another subset within that subset of fetuses who have these conditions that we can actually diagnose and treat, and also the maternal risk of surgery or procedures and anesthesia is acceptably low. And that's thanks to things like in the 1960s, the advent of fetal ultrasound, intrauterine blood transfusions, and then the advancements in fetal surgery in animals, in sheep, as well as in various medical disciplines like neonatology, anesthesiology, et cetera. And it's important to remember that to go through all these procedures, that every fetal procedure involves at least 2 patients. Right? So patient selection is key, and I've mentioned already several times that a completely healthy mother, as completely healthy as possible, is really key. One who will follow up with appointments and activity restrictions. And all these patients undergo extensive evaluation and screening with OBGYN, maternal fetal medicine, general surgery, genetics, social work, and of course anesthesia. So the pre-op for these moms is pretty standard. It's what we'd all do for all parturients. But they also go extensive imaging like fetal ultrasound, MRIs, genetic screening. And before any open surgery, I discussed later is a multidisciplinary team meeting that includes all the subspecialties and a sit-down between the anesthesiologist who's going to take care of the mother and fetus and and the family. I understand that do plenty of obstetrics here. I mean, no offense to the obstetric anesthesiologists who are listening to this talk. This is not meant to diminish the role. It's just to emphasize that this is why we, of course, try to select as healthy mothers as possible, because there are other risks involved with anesthesia in a parturient. I won't go through all these bullet slides. These bullet points, they've all been hammered into us as part of our education and training. Fortunately, because of the extensive evaluation process that takes place at CHOP, virtually all the mothers are about as healthy as can be and try to minimize as much as we can other risks in addition to these very basic fundamental ones. And because this talk is about maternal fetal anesthesia, we have to talk about anesthetic considerations in the fetus. I don't know how many mid-gestational, non-obstetric, non-fetal procedures you have to do in pregnant women here, but you always think about what we're giving to the mom also gets to, or most of what we give to the mom can also get to the baby. And the fetus has a stiffer myocardium. It's already at sort of the right end of the Starling curve, so the cardiac output's dependent less on preload and more on heart rate. In the second trimester, there's a stress response to stimulus that's ablated by opiates, so it's important to think about how you can keep, during these procedures that are invasive to the fetus, how to keep the fetus as comfortable or as possible. How do you deliver analgesia to a fetus? There's also increased sensitivity to volatile anesthetics that manifests as fetal bradycardia. And then, of course, there's a very tiny blood volumes. That is, if there is any blood loss, there's really very little reserved in terms of the fetus. So how do you monitor a fetus during one of these cases? In minimally invasive case, there's no opportunity to place EKG or pulse oximeter or anything of that nature. It's really just by fetal ultrasound, watch the heart rate and cardiac output. And then in open cases, we still use a fetal ultrasound, but we actually, if we can expose an extremity, we can attach a pulse oximeter, and that's really what, between those two things, fetal echocardiogram and pulse oximeter, that's what we use to guide our anesthetic. We should all keep in mind also that the important thing to maintain is placental perfusion and uterine blood flow, and these are also all things that, as we take care of parturients, know that aortic cable compression, hypotension, uterine contractions can all decrease uterine blood flow, and that's can be very, if uterine blood flow and placental perfusion is decreased, it can be deleterious to the fetus. Try to avoid all of these things. So that was the recap of all of maternal and fetal anesthesia or anesthetic considerations in 3 slides. We'll just go through some of the procedures that that take place at CHOP. But before we do, we have to talk about twins. So twins are adorable or hilarious. They're also magical and can save the world. So there are a lot of plus sides to twins. But unfortunately, monozygotic twins are also at increase for a lot of different complications that require interventions. The twins occur 1 in 90 pregnancies. Depending on when the split occurs after fertilization, determines whether they have 2 placentas or 1 amniotic sac, 2 amniotic sacs. It's between those days 3 and 9 where you have monochorionic diamniotic twins that you end up having problems, and that's because of the shared placenta. So you can see that in this situation, the placenta shared between 2 twins, and random vascular connections, blood vessels, can cause problems. And it's those problems that we try to address. And one of those problems that can occur when you have abnormal blood vessels in the placenta with monochorionic twins is that you have twin-twin transfusion syndrome. So there's a net flow of blood from one twin to the other, from the donor to the recipient, and that can result in hypovolemia and oligohydramnios in the donor twin, and then polyhydramnios and hypervolemia hydrops in the recipient. One way of treating this is serial amnioreduction, which is a way of temporizing the situation. You draw off the amniotic fluid and try to give some space to or take off the fluid in the recipient amniotic sac to try to give the donor a chance to grow and become unstuck. And then there's also the opportunity to visualize the placental vessels that are actually abnormal and then ablate them with the laser, so no longer is the net flow across from the donor to the recipient. And this is what this looks like from the outside. So you have a trocar placed in the mother's abdomen, and the fetoscope is passed until the placental vessels can be visualized, and then a laser filament is passed through that fetoscope to ablate the vessels. You know, think about how you would anesthetize a mom for a procedure like this, and you also have to think about you anesthetize a mom and also anesthetize the fetus so that the fetus isn't floating around and doing backflips and kicking and other thing while the laser is being advanced to the placenta. And this is just some of the evidence behind actually performing this laser ablation. This is a New England Journal of Medicine article from 2004. And the laser group, fewer deaths and improved neurologic outcomes by treating the actual cause rather than the symptoms of twin-twin transfusion. In a more severe case, you have a twin-reversed arterial perfusion sequence, or TRAPS. That's where one twin doesn't develop a heart and dies early. So the pump twin is not only providing their own cardiac output, but also still supplying the other twin. Imagine that doesn't work out so well when you're a fetus trying to pump to 2 whole bodies. and that in untreated, the pump twin dies in about 50 to 75% of these cases, so something should be done. One of the things that can be done, I didn't really include it as, shouldn't be included in a talk about minimally invasive procedures because it's about as maximally invasive as you can get, the sexio parva. Has anybody ever heard of sexio parva? That's a C-section to deliver the acardiac twin, and then closing everything back up again and hoping that the surviving twin actually develops and survives to gestate or to delivery. So that we don't really do anymore, and I don't know if anybody does, but it's just in the literature. What we do is bipolar cautery and radiofrequency ablation of the umbilical cord to the acardiac twin. And of course, as you can imagine, correct identification is essential. You don't want to be ablating the umbilical cord of the good twin. Other things that we do that are done at CHOP are for cystic, for lung cysts, they place thoracoamniotic shunts, and they do this under ultrasound guidance. Again, as you can imagine, trying to anesthetize mom so that she's comfortable, while also the maternal fetal mass docs place trocars and ultrasound guidance direct shunt to the thorax of the fetus in order to decompress the lung cyst. So a lot of different things, treating cardiac lesions, urinary tract obstructions, and all of these are done minimally invasively, try to address problems in the fetus before they advance and develop too far with these in place. This is the audience participation portion, very exciting. So you're going to anesthetize this patient. So we've already gone over fetal, maternal anesthetic considerations. You have a mom. She's 33 years old with monochorionic dianetic twins for laser ablation of placental vessels. How would you want to anesthetize a mom like this? How would you, is it just local and stiff upper lip, or some sedation, general anesthesia, neuraxial? There really isn't a wrong answer. How many would give local? How about just sedation but no general? General anesthesia. Okay, and then neuraxial, so CSE or something like that. Okay, great. So everybody's right. So it depends on, it's institutional. So other institutions are doing this. The at various institutions, they do neuraxial. They do CSEs at Cincinnati and also at Denver Children's. They also do, and used to do, general routinely for these procedures. And then we also can just do a little bit of local and a lot of local and a little bit of sedation. So a lot of ways to skin a cat, just like I'm sure many, there's no one way to really good certain anesthetics. This is the same sort of situation, but we had, this is talking about anecdotes. We had a patient who, history of anxiety, otherwise healthy, denies snoring or obstructive sleep apnea. But of course, as soon as she had a little bit of midazolam and Precedex, just started snoring up a storm and obstructing. And you can imagine trying to place a fetoscope and trying to ablate tiny blood vessels while a mom is snoring and her abdomen is heaving. Definitely not amenable to fetoscopic surgery. So that's actually, in that case, where general anesthesia was appropriate. I mentioned a little sedation, a lot of local is our approach at CHOP, but there, like I said, at other institutions, everybody has their own approach. What's interesting is that we all have these different approaches, and nobody has really studied yet what the ideal and what produces the best outcomes in these mothers. We try to avoid general anesthesia, at least at our institution, but it absolutely is, like in that situation I just mentioned earlier in the previous slide, definitely warranted. So I'll shift gears now from minimally invasive to the mid-gestation open procedures. The main indications are myelomeningocele and also impending fetal demise. And the anesthetic goals are similar to what we talked, or what you would expect: maintaining perfusion to the mother and the fetus, managing uterine relaxation so that the mother doesn't start contracting in the middle of a mid-gestation open procedure. That'd be pretty terrible. And then also analgesia for both the mother and the fetus. Just a reminder of what myelomeningocele is. You see the left side of the slide, there's a normal spine with the spinal cord and nice and intact and everything else. And as you shift over to the right in the slide toward the center, the myelomeningocele is actually where you have a defect in the usually in the lumbosacral area, and then you end up having meninges protruding through the bony defect. And this can result in paraplegia and urinary incontinence, hydrocephalus. These kids need BP shunts. And the traditional repair was performed postnatally after the babies were born, until there were these experiments and studies in 2000 into 2011, 2012, comparing repairing these defects while prenatally and against the outcomes in the postnatal period. And actually, this study was published in the New England Journal was stopped in the interim due to interim analysis that showed that the outcomes are so much better with prenatal repair. So that's what we do actually at the hospital. We take care of patients like this. A 27-year-old healthy G2P1, no prior surgery. Of course, 24 and 6/7 weeks. I should have just put 25 weeks, but yes, 24, 6/7 weeks, and fetus with an MMC and hindbrain herniation that pushes us toward prenatal repair. What kind of anesthesia are we going to do for this? Basically, going to involve a laparotomy, bringing out the uterus, a hysterotomy, bringing out the baby, repairing the defect, and then putting everything back in again. And waking up. Our approach is, I'm just going to run through this very quickly, is an epidural for post-op pain, because pain can cause stress, can cause uterine contractions. We do a rapid sequence induction, as you'd expect. We use high-dose inhalational anesthetic, and also place an A-line. And we have, as you can imagine, during these cases, competing priorities. We need to keep the uterus relaxed, but keeping it relaxed with inhalation anesthesia causes hypotension, which then we have to address with pressors. But at the same time, the inhalation anesthetic can cause fetal bradycardia, so if fetus starts to become bradycardic, we have to reduce our inhalation anesthetic, and it can be very challenging. And the whole time we're watching, or at least the cardiologist is watching the fetus with an ultrasound and calling out whether there's diminished cardiac output or diminished heart rate. We're doing this while also watching the field and keeping an eye on mom. The fetus does get intramuscular fentanyl and vecuronium to keep the baby still and also to provide analgesia. And we try to limit maternal fluids. In this kind of case, we open, mother gets opened up and everything else, and we still limit the maternal fluids to about 500 cc's of fluid at most. And it's important to start magnesium glycolysis toward the end of the surgery. So this is what it looks like. At least this is what a photo looks like of it. This is where the laparotomy has been performed. There's the uterus has been partially exteriorized. They've already ultrasounded to find the ideal window to get access to the fetus. And then you can see the blue arrow is pointing to a level 1 infuser that's constantly infusing warm lactated ringers to try to keep replacing the amniotic fluid that's lost. This uterus, it's kind of hard to tell from the photo, but it's pretty relaxed. It's nice and slack, so that, again, there's not too much contraction where the fetus can become compressed, and the umbilical cord can be kinked, and there can be issues with the fetal perfusion. And this is where the fetus has actually been exposed so that the defect is accessible to the neurosurgeon. They've already given the intramuscular shot of fentanyl and vecuronium. And it's during this time that it's obviously very important to keep the uterus relaxed, but then also at the same time, again, battling hypotension, keeping an eye on fetal bradycardia, and if we do reduce the inhalation anesthetic, giving nitroglycerin, but not too much so that we're not predisposing to pulmonary edema. It's a very high maintenance, but exciting cases to be a part of. Here's just, you can see the fetal ultrasound probe, so we're constantly watching it. And the myelomeningocele has been repaired, and the fetus has been returned to the uterus, and they're about to start closing. Actually, at this point also, that you can still have thinking of if you just don't keep an eye on the baby, and you're too high in your gas, there can be issues with fetal perfusion. You start having bradycardia even at these periods here. The nice thing about this case, though, is when you think about how traumatic this is, and if you have a good working epidural as an anesthesiologist, in cases where mom has been closed up, everything's fine, and extubate, and they ask when the surgery is going to start. The working epidural is great. So that's one of the most rewarding things, to have a patient whose fetus has just had had this laparotomy, hysterotomy, and then they want to know when their surgery is going to start. They complain a little bit about a sore throat. So you can see this is why in the first slide I had to take a photo of the screen rather than a photo of the field. There are 4 general surgeons here, pediatric cardiologists, maternal fetal medicine docs, all crowding around. This is how busy and crowded it can get during these cases. We rely very much on the fetal ultrasound and the monitors to get a sense of what's going on with the fetus. And this is just my view behind my fellow, and this is where I'm mentioning in my fellow's ear that you really need to grow a third eye for these cases, because you need one eye on the fetal ultrasound, one eye on the field, and then one eye on your vent and the maternal monitors. Because perturbations in mom can absolutely, if you don't watch hypotension in the mom, can actually hear and see the fetal bradycardia starting to occur in the fetal ultrasound. So it can be, again, very exciting, very stressful cases, but very rewarding in the end. Let's shift gears to lung cysts. I mentioned the thoracoamniotic shunts. And also in some cases where the lung cysts that are growing can start to impinge on the heart and also affect the development of the contralateral lung. So in those cases where the fetuses are looking potentially non-viable, one of the things we can also do is mid-gestational in utero resections. And it's very similar to the same thing, hysterotomy. Sorry, that would be really tough without a laparotomy first. Laparotomy, hysterotomy, bringing out just the portions of the baby that need to be accessed for surgery. In this case, we actually can get a fetal pulse ox, get a little bit more monitoring of the fetus, get access to the thorax, and then resect the lung cyst. So there are 2 examples of mid-gestational open fetal surgery that we do at institution, and some of the you see the anesthetic challenges are trying to balance maternal and fetal physiologies along with trying to maintain or produce ideal surgical conditions. A lot of fun. So the late gestation therapies, we call it ex utero intrapartum treatment, and that's trying to keep the fetus at the end of the fetus has a condition. They try to let them gestate as long as possible, but they have a condition where if you just deliver them, they'll be immediately at risk. So these are things like airway anomalies that are obstructing the airway, and then lung lesions that impede ventilation. So the fetus is delivered via C-section. Only the parts that are needed, that need access to, are delivered, and the fetus remains on placental support. So we still have the oxygenation via the placenta for as long as possible. Then other types of things we do, impacts and prestos, are just other variations on a theme. In the presto, this is what we call the section to resection, where the C-section occurs. And to take the fetus, or now the neonate, directly from the C-section room to the fetal operating room and start performing the surgery there. These are just examples of the kind of airway anomalies that can occur in neonates and fetuses that require these types of exit procedures, the ex utero intrapartum therapy. One of these conditions is chaos syndrome, where you just have an atretic trachea or larynx, and there's no egress of lung fluid. Remember, the lungs produce amniotic fluid. As they produce amniotic fluid, there's egress out of the trachea. If it can't get out, it actually just accumulates, and it can lead to fluid accumulation and death. And then also mention airway masses. So just recently took care of a child, and we'll see some slides. We have cystic hygromas, so large cysts that occur in the neck, and then teratomas that also can affect the airway. You can imagine if this baby were delivered, trying to secure an airway in a baby in a 0-day-old who has decreased FRC, increased oxygen metabolism, be very challenging and very stressful. So try to create a more controlled situation where the neonate or the fetus is on placental support. Here's an example just from 2 weeks ago. This patient is a cystic hygroma, actually a cervical lymphangioma that crossed the midline of the neck. So performing an exit procedure and then placing a tracheostomy would have been impossible. You can see the importance of fetal MRI in these cases. We can try to get a sense of the airway and the approach you're going to take. This is an ENT physician performing flexible bronchoscopy. While it's hard to see, but the baby is still actually just the head and the upper arm, the left arm and the upper chest were exposed through the hysterotomy. And off to the side is one of my colleagues. So during these procedures, we don't only give the anesthesia to the mom, but sometimes we also help with the line placement in the fetus that's partially delivered. And then this is the baby. So you can see a very large mass that's, again, taking up most of the left side of the face. It covers the neck. But fortunately, because they were able to secure the airway on placental support, we didn't have to deal with trying to intubate this child before or after separation from the mother, which could have been a potential disaster. Just a few studies about survival. It's really dependent on the type of cyst or teratoma that's affecting the airway. Moving on to another condition, congenital diaphragmatic hernia, where you have eventration of the abdominal contents up into the thorax. Some of the treatments include tracheal occlusion balloons. Anybody heard about those? To try to place a balloon in the trachea of a fetus. So how this occurs is, this is a mid-gestational, minimally invasive procedure where the general surgeons, as we anesthetize mom, and there are different approaches to this as well, will place a fetoscope through the abdominal wall, through the uterine wall, and then into the mouth of the, the orificial passage, and then place a balloon in the trachea. So you imagine the anesthetic management for these cases can be interesting as well. At first we did general anesthesia, general endotracheal anesthesia for these cases, and now we've moved to sedation. But the sedation is a little bit more harrowing because we always worry about mom fucking or coughing or having the heaving motions, while the trocar and everything, the fetoscope is in the airway of the fetus. The balloon is lodged there, inflated and left. And the thought is, I just mentioned that the lungs produce amniotic fluid, so if you have a balloon in place, and you're sort of creating the chaos syndrome where you have no egress of fluid, so then the lungs produce amniotic fluid and start to push down everything that doesn't belong, which is abdominal content. The problem is you now have a balloon in the trachea of a baby, and then you have to get it out. So the way that's done is an exit procedure. Keep the mom under general anesthesia, thoracic epidural, all that stuff. Partially delivered baby. You can see that on the left side of the screen. Baby gets a baby shot of fentanyl, vecuronium, atropine, and the general surgeons direct laryngoscopy and go in and retrieve the balloon. And it's for the most part gone pretty well. Haven't had any of the catastrophes that I think could happen, like what happens if you accidentally push the balloon a little further, if you pop the balloon and now you have ragged edges. Thankfully, that hasn't been a problem. I think and then sacrococcygeal teratomas are just, as you know, highly vascularized masses in the sacrococcygeal area. You can have a vascular steal effect, local mass effect, and this can be, again, this can be fatal for neonates, fetuses. So some cases, these are cases where it's rare for us to do mid-gestational open procedures for SCTs, but we do a lot of section to resection where the babies are delivered and then go directly to the operating room. And this is the last good situation I've had with a 0-day-old, had a baby with an SCT, 1.6 kilos total body weight, and the mass was estimated as 800 grams. So about half the body weight was just this mass on the backside. Case went very well, and then at the very end, we started giving a little bit more blood out of the second half of a unit, and then just a complete flatline. Just watched the T waves got peaked, and then suddenly the A-line tracing just vanished. Baby started turning purple. Fortunately, we had an IV in place. We were able to give epinephrine, and then started doing prone chest compressions on a 0-day-old. Very similar to it was very similar to playing video games, like an Xbox. I don't know if all those years of playing video games where my mom was saying it was just totally a waste of time. Yeah, there you go, Mom. Actually, it really worked out well. So don't knock Xboxes. Or I'm sorry, I should say any sort of video game, and you should not just pick one. But yes, actually worked out pretty well. And baby did fine. I wouldn't tell the story if the baby didn't do well. And then, okay, so now anesthesia for this type of exit procedure. Now we're toward the end of the gestation. Healthy mom, of course. Fetus with a large airway mass. And we sort of already discussed this, right? It's actually very similar to mid-gestation open procedure. But thankfully, we don't have to be limited to just 500 cc's of fluid. The concerns about postoperative pulmonary edema aren't as great in this stage as they are during mid-gestation. And instead of tocolysis, of course, we want to combat uterine atony after the baby is out. So the baby gets delivered, it is a C-section. We still have the epidural in place for some reason. I don't know, we just can't get out of that habit. But it does seem to help with the postoperative pain, and then eventually we end up giving the Duramorph and then pulling the epidural. So taking to the end of the talk, the future of maternal fetal anesthesia, maternal fetal medicine, and surgery. There's intrauterine gene therapy. I don't know if you've ever heard of this, but being able to deliver through those trocars, through the fetoscope or ultrasound-guided delivery of gene therapy. And you can imagine that gene therapy medications are expensive. It's really difficult to develop one, and then when you finally do and it works, it's phenomenally expensive. So if you can deliver the gene therapy medication as early as possible when the baby isn't even born yet, when they're fetus, and you're actually delivering the gene therapy medication to a smaller cluster of cells, smaller mass, so you can get a better effect. That's one of the ideal goals of this sort of technique. Also, minimally invasive surgery. Can you do these sorts, instead of opening mom, can you do an MMC repair just with very similar to laparoscopy? And then lastly, artificial womb. I don't know if you've ever heard of this, but one of the surgeons at CHOP, his lab has built this whole artificial womb. These are images from nature. With sheep, been able to show that in an actual development with outside of a regular sheep, so the lambs are actually able to grow and develop within the artificial womb, and neurologically so far really similar to we expect at baseline. So will there just no longer be maternal fetal anesthesia for case open mid-gestational? Instead, if the baby has MMC, take the baby out of mom, fix the MMC, and then put the baby in an artificial womb? I don't know. But if we do end up doing that, I'll let you know. These are just some of the articles if you're interested. Happy to share them if you want to email me and can send you copies. But thank you all for your attention. I'm one of 8. We have a department of about 50 or 60 anesthesiologists, but 8 of us are lucky enough to be able to take care of moms and their fetuses, and I'm very honored to speak to you today and be able to share some of our experiences. I welcome any questions. That's pretty much it. Thank you very much for your attention, for coming. Just going to turn on the audience mic. Thank you.
I just had a quick question about giving the fetus intramuscular injections. Because at that point in time, your blood clotting is not ideal. Have you guys ever run into any situations where it's caused harm?
So the question is about causing harm with the intramuscular injection in the fetus. We use smallest thing we have is a 30 gauge. So far, we haven't run into, and you're correct, absolutely, that the coagulation factors in the fetus are suboptimal compared to one patient. We have not had significant problems with hematoma formation or bleeding after a 30 gauge needle, usually given in the buttocks or in the leg. Not yet. That's a great question. Hopefully not. We always that portion that injection is done and usually. Well, I should say it has not ever caused a problem yet. Thank you. Yes?
What sort of cost are you looking at for this, and who actually funds it?
Costs. Unfortunately, I don't have much. I haven't really dealt with the billing portion of this or how much it costs to perform these. I don't have the answer for you, but I can find out and get back to you. So I don't know how much it costs. In terms of funding, this is, I know all of the reason I mentioned social work is they handle all of the insurance, and these moms after these mid-gestationals have to stay close to a center that can support in these cases, mothers and fetuses. And that all obviously costs a lot of money to be staying at their hotels, Ronald McDonald House, things like that. But fortunately, I don't have to deal with too much of that management. Social work does, but if email me, I can find out and get back to you. I'm sorry, I don't have those numbers for you.
Are we currently doing any surgery like this in Canada?
I was asking around at BC Children's. I believe that there are a few exit procedures a year at the women's system.
At BC Women?
From what I understand, I'm not sure, but I heard that there are. They were saying that there are at least a few, very very few of those. But the other thing is, I mentioned the section to resection, so that's always not quite an exit procedure, but as close as you get. Having immediate fetal surgical repair available after delivery, and that's what the situation is here. I haven't heard of too many centers. Many centers doing a lot of open mid-gestational MMC repairs in Canada. There are actually very few in the U.S. Only a handful. There's Cincinnati, Denver Children's, UCSF. I'm missing.
And the outcomes of these fetuses, infants later on, was good, despite being exposed to the drug and the procedures?
Yes. So all of these children are followed by the surgeons. They get developmental testing at regular intervals afterward. That includes the CDH repairs and phalangeals. These children as well, the mid-gestational MMC repairs. The results are mixed in terms of their developmental outcomes. The challenge there is, what would their outcome have been developmentally if you didn't do the surgery? Because then you'd be trading off perhaps the exposure to anesthesia and everything else for pretty much guaranteed paraplegia and urinary incontinence and a ventricular peritoneal shunt that would also require anesthesia. So there isn't really good evidence, right? They are followed, but there isn't really good evidence right now. What is the best? What is the most favorable outcome, or what deleterious outcome are you willing to tolerate in terms of either having that early exposure to anesthesia versus guaranteed paraplegia, urinary incontinence? Does that answer your question? I'm sorry if
Yeah, I just wanted to see if they grew and thrived.
I didn't include the slides here, but they do grow and thrive, and actually every year CHOP sponsors hosts sort of like a return to CHOP event where you see families, friends, and the patients themselves come back, and it's phenomenal. And you see these patients, and you never guess that they were fetuses that underwent surgery at 24 weeks. It's amazing. It's not 100%, obviously, but it's really remarkable to see some of these results. These kids are running around bouncy castles and everything else. And if they hadn't had the surgery, you can imagine that might be the result.
Yes. You almost answered the question I was going to ask. I'll just rephrase it a little bit. With all the concern in the literature about exposure of children to anesthetics, I assume that the effects would be the same for a fetus who's exposed to a general anesthetic administered to mom neurodevelopmentally. And is there any concern with just deep sedation and with like a local sedation procedure? Is there any concern about sedation to the mom causing neurodevelopmental effects on a fetus?
Yes, that's a great question. It's a hot topic. It was a hot topic in pediatric anesthesia. So neurotoxicity is a concern, and that is part of one of the projects I'm actually working on in terms of looking at anesthetic exposure with some of these cases, general surgery cases, cardiac and surgery cases. If we can minimize the exposure to the fetus as much as possible, we do. The challenge is also, at least in the mid-gestationals, maintaining uterine relaxation. If we go too overboard with the nitroglycerin, we're concerned about postoperative pulmonary edema. And it's always trying to weigh and balance, again, every case having two patients. What is acceptable risk to a healthy mother, placing them at risk for complications in order to treat their unfortunately affected fetus. But absolutely, we try during those minimally invasive cases to try to minimize the exposure of the fetus. That's why we try to avoid the general anesthesia if possible, because then in that case we are giving volatile anesthetic mother, we hopefully could have just gotten by with midazolam and precedent. The fetal studies looking at exposure to antidepressants, there aren't really any in humans, they're mostly in sheep. And best of my knowledge, the concerns of vaccine autonomy exposure and neurological development in the fetus, concerns aren't as bad as exposing the fetus to isoflurane, halothane, inhalational anesthetics. Did I answer all the parts of your question? I'm sorry. Well,
Pretty much, I think so. So I guess one further question would be that would Tiva be more neurologically friendly than using volatile anesthetics?
it would be, yes. And there is a publication out from Cincinnati, it was 2013, 2014, looking at supplemental intravenous anesthesia. They didn't quite bring MAC from 1.5 to 0 with Tiva. They started to give it around 0.6 MAC with inhalational anesthetic, and then supplemented with Tiva and actually found acceptable surgical conditions, but overall decreased exposure to the fetus. That is something that I think would be great at our institution as well. There's always a challenge trying to change the direction of a oil tank. It's happy steaming along a certain way, but absolutely there is the opportunity to reduce volatile anesthetics exposure to published and shared in the literature. Great. All right. Any questions or anything else? All right. Wonderful. Thank you very much.
Thanks.
For your time. Thank you.